Pod Patrol, Season 2, Episode 1. Today I'm joined by Dr. Jacob Wynes. Thanks for joining me, Jacob.
Thanks for having me.
Joining me tonight on Episode 1. That's a big honor. No pressure there. You got to kick it off right. Season 2, we're going to hit the ground running. Yeah. So you're out in Baltimore right now, University of Maryland. Tell us your story, kind of how you got to where you're at right now, and then we'll kind of take off from there.
Great. Well, my first job since working at McDonald's, actually. So
that's quite the step.
I know, right?
What are you doing? Fry guy, cashier?
Actually, I was very good. I always consider myself to be quite the overachiever. I had done a frontline, grill, and drive-through. I was able to do all three.
Nice.
And I shortly ended up quitting when they asked me to snake a toilet in the dining area.
Oh, yeah. You got to draw the line.
I was also living across the street, and they would have me shovel the driveway and the sidewalk for the construction people at like 4 o'clock in the morning, knowing that I lived close.
You think they'd be nicer to the people that have half a brain, and they're like, we got to keep this guy. Like,
I know.
Get someone else to snake the toilet. Get someone else to do that. We got to keep this guy. Nope, they blew it.
Well, I mean, probably, yeah, I don't know.
Otherwise, you might still be there today.
I probably could be.
Upper middle management.
The worst thing about it is the uniforms. They were like a pinkish kind of. I mean, that's anything wrong with. I mean, I think
Yeah.
Men can wear pink. I just didn't love it. And
sure, it's not for you.
There was also an issue where they could only give me a visor. I couldn't really get a hat.
You didn't advance to hat level yet.
I know. No, so I did grad school after undergrad, and then did podiatric medical school at Temple, and the residency at Penn, and then did a fellowship with Brad Lamb out at Sinai Hospital at Lifebridge.
So for those who don't know, that's limb deformity, reconstructive, kind of intense, probably the most well-known reconstructive limb deformity fellowship in the country for anyone listening. But now you're involved with your own fellowship, correct?
Yes. Yeah. So I think the interesting thing is that I am 45. So I am 5 years older than Dr. Lamb was when I was his fellow. So I was there for his 40th birthday, which meant it's just a weird position for me philosophically, like to deal with how, aging and career trajectories and how fast everything goes. Mm-hmm. I mean, it's lightning quick, and I'm matriculating my 6th fellows. So I graduated 5 toes on one foot. I'm onto the big toe on the opposite.
There you go.
So it's really amazing. And, one can look at it 2 ways, but, when your mentor finally recognizes you, I think it's really a good thing. And for that, I'm pretty grateful. Yeah. Also to see that the technical apple didn't fall too far from the tree, meaning that in a lot of ways, I still think we do things somewhat similar. I do think that Dr. Lamb's a genius, and I do believe that he really has pioneered a lot of what we know to be deformity in the foot and ankle space. I would say the godfathers of taking the principles of Paley and Herzenberg and adopting them to what we do as podiatric surgeons, I think would start with Dr. Guido Laporta and Bob Mendocino, who are both mentors of Brad Lamb as well. And I think for those guys that have really paved the way for us to really get involved in distraction osteogenesis and being able to do the things that we do and think about deformity correction, I think is really commendable. So for that, I think it's just really awesome. And it's great. It's branched out. Still not super popular even amongst the orthopedic community, but I do think it's a valuable skill to have, and I'm very fortunate to have had the training.
Yeah, so talk about kind of what your fellow will and does do with you. Kind of sell your fellowship just for a minute for anyone listening who might be interested.
Yeah, I really appreciate that too. I'm very proud of it. I think the thing that really gets me excited is that through some campaigning and some Shark Tank-esque type of presentations I had to give to the hospital system, Maryland is a waiver state that through the HSCRC and through CMS, it does not fund podiatric medical education or graduate medical education. So from that perspective, I had to pitch to the hospital the importance of standing behind a fellowship and why it would be worth it within podiatry. Then I had to find a department to sponsor it. I'm part of the Department of Orthopedics. So I got them to say that this would not be a bad idea to have a fellowship. Originally, they wanted to have it as sort of a junior associate type position, but for me, I don't think that was good enough. I really have valued the fact that I went to the Graduate Medical Education Committee and petitioned this as a fellowship that deserves the same recognition as a ACGME or non-ACGME program under GME. Mm-hmm. And with that, I was able to get that co-sponsored. So it's co-sponsored by both orthopedics and by the GME committee. And I think for that, I think that's really what's amazing is that at any point in anyone's time, and I don't think University of Maryland's really going anywhere, the fellow or whoever's looking at the fellow can always call the university and say, hey, was this doctor ever a fellow here? And I think that's really great. So taking you through what we do, it is a referral center for urban Baltimore, but also within my own practice, establishing those referrals and through grassroots efforts, sort of taking a similar approach of being able to collaborate with other, treating DPMs in the community. Occasionally some orthopedic surgeons may send some stuff my way too, which is incredibly flattering, but more, I would say it's the DPM community that in an effort to kind of provide comprehensive care for their patients or deal with some revision surgery. I think it's been quite amazing to have that, I guess, collegial sort of environment that I function in. So we do revision work, non-union, malunion of the midfoot, hindfoot, dare I say forefoot. My second MTP game is still not, I'm not going to say it's perfect. I don't know whose is. And for that, I would probably even give up my job if I could take a break from my salary and study under that person for a year. Look, I'm looking for my Yoda of a second MTP, but outside of that, I think we have a pretty good grasp on things. Over time, you're really not the same surgeon you once started off as. And I think very honestly, I learn from every case still. So we do some distraction osteogenesis, distal tibia, collaborate with orthopedic colleagues for proximal tibial lengthenings. They oftentimes will consult me for post-traumatic deformity with hexapods. I think that's a part of the program. We deal with a lot of congenital and syndromic cases, some very sad cases of children in the NICU and, urban city Baltimore does provide a unique population for that. It's not a lot of walk-in business. Some of it is just you're the person that they need at the time. And then, I've been, I think as people get older, they start realizing that they've done a lot in their lives. They've taken care of their loved ones. And when they realize there's nothing left, they start realizing their aches and pains. And we recently put out a paper on elderly Charcot. And I would say about 22% of my patients are over 65 that have gotten major foot and ankle reconstructions. And I still think my 70, 80-year-olds are doing fantastic. They barely complain. Except for when you leave them in the treatment room for too long and they
or it's a little chilly.
Yeah,
they don't like it. Can I put my socks back on? They don't like it when it's chilly.
Yeah, they're like, what about me?
Otherwise they're happy.
Exactly.
So I wrote down here, you see non-unions and revisions. What's your address? Just in case I need to tell any of my patients.
22 South Green Street.
Baltimore, Maryland.
Baltimore, right.
You might have an influx of people from Iowa.
No, but also, I don't want to cast stones either. I do get non-unions. I do get malunions. I'm not going to say that never happens or that I'm like the non-complication person.
Yeah.
But I'll tell you what, it's given me a lot of pause when I have post or preoperative discussions with patients. That is, I was just talking to my fellow about this the other day. I think some of the most difficult discussions to have with a patient is the expectation or their surprise when they do get a non-union. I find those to be the most challenging. A raging osteomyelitis or infection, like forget it. I could talk them off the ledge like all day, but a non-union, it's like this long drawn out, why did this happen? What did you do? What am I looking at?
Yeah.
I just had a lady, I did a perfect lapidus on and she looks at her sesamoid bone. She's like, the bump's still there. I'm like, no, that's not the bump.
Yeah. That's hard.
It's hard. So, yes, I'm very, like having seen things and I also will use the adage that I try not to put hardware in that I can't take out.
Yeah.
Because that's the other thing that surprises patients too. I'm sure the other question you get is, am I going to have to get a card for the metal detector at the airport?
Oh, they love that one. They love that one.
They love it.
I'm like, you're going to get pulled out of line. You're going to hate it. You're going to get wanded.
Exactly.
They worry. Yeah, it's interesting. Non-unions are tough because I can do the same exact surgery on two different patients. I do it the exact same way. Yep. One gets a non-union, one doesn't. And I'm scratching my head. Later, I come to find out, okay, vitamin D deficiency. And then you start wondering, should we be checking vitamin D on every patient preoperatively? Do they want to pay for it if it's not covered by their insurance? All these things you can walk yourself down the road trying to figure out, like, what could I have done differently? But yeah, non-unions are so tough. As long as you do the same thing, you adequately prep the joint. Sometimes it's just patient, things happen. So it's hard to predict.
It's got to look opposed on fluoro. I think that's a big thing to look for. I fish scale, I fenestrate, I prep, the irony too is that sometimes the worse the arthritis, the more subchondral sclerosis you get.
Mm-hmm.
And the harder it is to really get adequate joint prep. I just think it's the weirdest, most peculiar thing in the community. If you do have someone that's not going to back you up in the community, to get it as a second opinion, to question why a non-union occurred. I mean, unless it's egregious, unless the joints aren't prepped or something. Right. But even so, I mean, it does amaze me too. I mean, fixation constructs, at least I was taught that it's a race between the hardware breaking and the bone fusing.
Sure. That makes sense.
There's big screws, little screws, headless, headed. Are you a headless guy or a headed guy?
Depends on the surgery, but I'm mostly headless.
Yep.
But you can argue how much compression you're getting with a headless screw versus a head dead screw. But I'm you weigh the pros and cons of compression versus prominence of the screw head, and it depends on a lot of parts of the foot. There's not a lot of meat there. That's what I tell my patients. Like, we got to hide these screws under the bone, because you're looking at the top of the foot for a lapidus or the back of the heel for a subtalar joint. Oh man, they feel those things and they don't like that one bit.
Nope. No, those posterior subtalar screws, I think, are a big cause of pain.
Mm-hmm, for sure. So you did a fellowship. Obviously, we talked about that. Yeah. That's kind of the latest and greatest thing in our profession. Do you think that fellowship is... Obviously, it's beneficial if you're going to do a fellowship that's in a highly specialized area like you did. So let's exclude that for 1 second. What are the other pros of fellowship? Are you pro fellowship, or do you think it's getting a little out of hand?
Yes and yes.
Okay.
So, yeah, I mean, I think those are two separate kind of questions there. I'm pro fellowship because the typical residency, to my knowledge, and I'm not sure of how many single resident per year programs there are. I just think it's a lot for a director to mentor. Mm-hmm. And I think it's a lot for a director to really, even if it's like 3 people, I mean, that might be doable, but I think the mentorship is by far a huge advantage of the fellowship experience.
Sure.
Being able to really have a pulse on their strengths day to day and having that continuity, not continuity of care with seeing post-ops and such, because that, I mean, yes, that's important, but it's not as important as the educator having a great grasp or a strong understanding as to what their trainee is actively seeking, what their knowledge base is looking like day to day, and looking for improvement and areas to improve, and also establishing a clear pathway where people can learn to adapt to constructive criticism. So that, I don't think, can happen in a traditional residency environment unless there's a very tight-knit connection. You train at a very prestigious place with very good resident educators. The one thing about the fellowship that I think can set residency apart, and I can't speak for all residencies across the country because it's definitely a big overstated type of statement, but what I'll say is that a fellow that's coming to me wants to spend that extra year, and it's a voluntary year to get extra training. So they know that they're trying to get more of what they came for, as opposed to residency, where I don't know if we know who's there just because it's something that they have to do to go through the steps, or is it something that they're going to really seek to get the most out of? And it's a mental thing. I think, and I'm sure you know this as good as anyone, that you could be a mediocre student, go to a bad program and get a lot out of it if you're motivated, mm-hmm. or you could be that same mediocre student, go to a place that has a lot of resources and not really try all that hard and maybe not see that you've gotten anything out of it.
Yeah.
Understanding that it's, again, I would like to say that my fellow has a lot of knife time, but residency is interesting. Residency is a process by which typically the one resident that is the least prepared gets the knife the less, or gets the knife the least. Mm-hmm. And the strongest resident gets it the most. Mm-hmm. It's kind of like a lopsided type of perspective.
Yeah.
So I do think that fellowships are important if they're like a niche-based fellowship and you want to add to some area that you've not gotten previously. In our case, it's like X-Fix and Deformity. But there are opportunities now that exist for folks that may need a little extra because, there may be a residency program that's been impacted by COVID. There may be a residency program where faculty has changed and they may not have had as much opportunity as they would have hoped for. So I'm pro fellowship, provided that the fellow who's applying knows why they're doing the fellowship and what their goals are. It is not a means to make more money in our profession. It is not a means of getting added clout. I don't think. I think that your work will speak for itself, and I think that's kind of my long-winded explanation for what I think about fellowships.
Yeah, I think that's reasonable. I completely agree with you. So if the fellowship is highly specialized in whatever it may be, and it's an area in residency that you didn't get enough experience in, it makes 100% sense to go on and do that added year of training, especially if that's something that you anticipate doing. Where I practice, I do mostly trauma, mild, like low level reconstructions, like triples, no Charcot, no frames, anything like that. It would have been a waste of a year for me to go and do a reconstructive fellowship. And part of that is hard to predict. You don't know what setting you're going to end up in. But as long as you anticipate utilizing those skills in the future, then yeah, I think it's significantly valuable for those people involved in that fellowship. And you're never going to come out worse for wear. I mean, you come out 1 year later, but you're never going to come out, any worse for wear. As long as the fellowship is reputable and is not treating you as cheap labor, I think that's a reasonable stance. So you work with residents, and you talked about giving up the knife. I mean, I think that would be difficult. Like I've mentioned in previous episodes, Dr. Jeff Manway became an attending. His first year at UPMC was my first year as a resident. And then instantly the resident's like, here, can I have it? And you're like, not yet. I need to figure out what I'm doing first, because I haven't even, established how I fix things and how I do things yet. So talk about that for a minute. Talk about your involvement with residents and how you handle who gets involved and at what level.
Yeah, I think that's a great question. That's really the crux of where there's a divide amongst the pro-resident initiative and the pro-fellowship initiative, because right now the American College of Foot and Ankle Surgeons, to maintain your recognition status, requires that you have an agreement between both parties that it's not going to diminish the educational experiences of the residents. I think that it's a lot about trust. It's more than just how the hand skills are. As you've probably experienced, being an attending faculty, things happen, and it depends on, how quickly or not so quick, even if it does happen, that you're able to fix those situations. From my perspective, I like to get a pulse on the dedication of the resident, meaning that if they're prepared and they know roughly, I'll ask very simple questions like, what are the structures at risk here? Like, what are we trying to avoid? Like, what is your goal? And if they're not sure where they're going to retract, it's very hard to allow them to participate fully into the surgical process. And very similar for the fellow too. If it's something that is, like more of a finesse thing, I'll say, hey, look, I'm going to show you how this is done. And I'm very big in see one, do one, teach one. I think when you're dealing with revision and some deformity stuff too, it's descriptions become much more challenging to do and have it done the way that you see it going in your head. So from that perspective, if I can't adequately articulate what it's going to be, then I too will take the knife. But other than that, the fellow gets the knife. And then as far as the resident involvement, a lot of my cases are they have like several parts. I might be doing and we may get into this later, but like cavus reconstruction, I might be doing a Steiner stripping, an abductor recession. I might be doing a PT tendon transfer. I might be doing a DFWO. I might be doing a Dwyer. So all these little parts, I pre-negotiate with them, be like, hey, do you need help with more bone work? Do you want to look at the soft tissues? How are you with tendon transfers? Have you ever used the Biotino screw before? So we have all this kind of pre-operative discussion that happens. And I'm guilty of this. I don't do this all the time, but it runs a lot smoother when you have these preconceived understanding as to who's going to do what when. Because oftentimes some of it too, and my own former fellow, Dr. Dubois, kind of picked up on this too, that if you take a resident who's like cold off the bench, they're just not going to perform well.
Yeah.
They got to be ready. They got to be doing their practice pitches and their practice swings and getting ready. Because if you're like, all right, here, throw this screw, and you're like, ah.
Yeah. Forget how to hold it.
Yeah, exactly. And then, they get nervous because they know it's not all eyes on them, but certainly I'm sure you're guilty of this too. And I am, that if they're fumbling and I've had residents like a screw through a plate. It's like missed the plate. It's like behind the bone. And they're like, man, this bone's soft. I'm like, what are you talking about?
Yeah, it's an adventure. Back to residency, my residency director, Dr. Burns, would always say, believe me, there is nothing that you can do that I can't fix. I'm not going to let you do something that I can't fix. And that kind of gave you this little safety blanket, this little guy walking along the high wire, but there's a net underneath. Walk across the wire, but there's a little safety net under there. So it give you this kind of peace of mind, okay, I can be a little more aggressive. If he's let me go, then I'm in the right place for my dissection. Because sometimes people want to do this little this little tiny little nibbles of the
cell layer by
15
cell
blade.
layer. Yep.
Yeah. And you're like, no, we're not doing that. That's not going to get it done. We need like, boom, boom, like get it done.
It's got to be deliberate. And I joke, it's like you're not working at a deli. You're not like finely slicing the pastrami. You know what I mean?
Yeah.
It's
we
also
don't
not
want
like
that.
an Avrolab. Like, I don't need to see every layer.
Yeah. We're not, that's going to be impossible. I'm not closing 10 layers. We're not doing that. So just get down there, get going.
But things happen. I mean, it's I appreciate that too, and I do think that somebody that's involved in training needs to also have that mentality that they are able to fix things. And I think not to be high on myself, but that took time. Having seen some of the things that I've seen, I mean, luckily things have been fine, and I'm very proud of both my residents and proud of my fellow, and it's been good. Very rewarding experience for me. Yeah. I've heard stories of some of my friends that are in like surgery centers having to teach the scrub tech who clearly gives no shits about like what they're telling them. Like, oh, this is so amazing. Like, look at this anatomy. And they're like, okay.
Yeah, it's an adventure. I have students that rotate through with me, and they're third year students, so they're pretty early on, and I let them do some things and learn how to throw screws and wires, and they still have that excitement. They still have that, yes. Like, it kind of gives me a little bit like, yes, this is cool, isn't it? Yes, like, all right, this is interesting. This is fresh and new. Because otherwise, sometimes you get out on your own. You don't have that fresh perspective, and everything is more just, going through the motions.
Yeah, I mean, it's so impactful when like a fellow resident will say, wow, like I really learned this and that was cool. I don't know why, but that gets me excited. I'm in this peculiar situation where I'm very busy and very consistently busy with like recon cases. And then you almost start wondering like, yeah, it's cool. No one really cares. I mean, honestly, I've gotten more cards from a good bros trim than I have for like saving limbs.
Yeah.
I mean, I got a Red Lobster gift card the other day.
Nice.
That was really cool.
I used to bartend at Red Lobster.
Nice.
I was slinging lobsteritas.
Oh my God, that's great. I've always wanted to be a bartender. Unfortunately, they had me work bar back before I could bartend. And before bar backing, I had to work security.
Oh. How'd that go?
Not bad, not bad.
Yeah, you're into what? I don't remember what you're into. Jiu-jitsu. What?
Yeah, it was jiu-jitsu.
Okay, so, all right.
There's a wall here. Sorry, let me see if I can show you.
Yeah.
That's my wall of karate. That's me getting my blue belt from Hoist Gracie, and then me like nerding out in Kempo karate when I was a kid. And those are my MMA gloves.
Awesome.
Yeah.
So you could handle yourself if someone gets a little rowdy.
So.
Yeah. You could. How about this? I'll go back to bartend at Club RL. That's what my friends called it, Club RL, Red Lobster, and you can be my security guy. We still got it. I'm sure of it.
Oh, that's great. No, it's always I just never understood last call. Like the lights turn on and it's like, what are you doing? Like pounding shots at like 1:30. Like, where are you going?
Yeah, I don't know.
DUI, you're going to make some really bad decisions.
Right.
Like, nothing good's going to happen after 1:30.
Never. And my mom always said nothing good happens after midnight. So.
Yep.
All right, let's switch gears a little bit. Let's talk about when someone comes in for a recon, because you're a tertiary referral system, I assume.
Yep.
And you're getting the complicated of the complicated. You're getting these cases that when you look at the x-ray, you look at the patient, you're like, whew. And it's going to be very difficult. You got to like start at square one. So let's work up an imaginary patient real quick. So what are your first things you're doing? Obviously, you're talking to the patient. You're walking them through, okay, let's get some x-rays. Let's talk through the treatment options. And then how do you start with a kind of standard reconstructive patient that the complexity of which that most of us don't normally see?
So, I mean, that's a great question. I'll never usually get something cold that's usually been seen somewhere else. But I'm sure you've gotten this. So you saw Dr. Smith. It was in some outside hospital. Oh, they should have sent the records. Oh, I got x-rays. And they pull up like a 1998 like x-ray report that they're calling an MRI. And I'm like, oh my God, this is not going to be good. And they're like angry.
They bring a disc and the disc doesn't work. And you're like, oh my God.
Yep. Like a CD-ROM. Like who even has one of those?
Yeah. I have to
Yeah. So, I mean, but in all seriousness, I do try to ask them what they've done conservatively. And there's still a handful of problems with really bad deformity and bad radiographic changes that I'm just unclear to what extent we can conservatively manage these people. Some of them have been in boots for like years. I mean, that in and of itself, I challenge anyone that's listening here, just because I actually just did this today. I had to run up the stairs and I can only get one shoe on, but even just wearing one tennis shoe and the other foot having a sock, it's a very peculiar feeling. Like your gait's off, like things just don't feel right. And I used to make fun of patients that were like, oh, my boot's too heavy and I can't do this. I can't do this. But the reality is, even like a sneaker comparable to your other foot having nothing on is still a very uncomfortable situation. I do think that boots cause tendonitis. So anyway, going back to the workup, always start with plain film radiographs, always weight bearing. And then from there, I take a hindfoot axial views. So something I've been brainwashed with for my fellowship was having a Saltzman box built, which for those that don't know, it's a wooden box that has a plexiglass that's on top, and then a angled holder for film that comes in at 20 degrees. And this beam is angled 20 degrees towards the ankle. And it captures the angle at base of gait. According to literature, it's supposed to be pretty analogous to resting calcaneal stance position, as opposed to the charger view or that calcaneal axial view that patients stand in to get the calc axial, which is the intrinsic tuber varus. Sometimes deformities, you can use the intrinsic tuber varus when you're doing a Dwyer, because it's usually an intrinsic tuber varus type problem. But to know where they're standing and where that calcaneus central axis hits relative to tibia, I think the Saltzman is great. And you being of Pittsburgh descent, I'm sure you guys are very intimate with hindfoot views.
Well, it can change your outlook significantly. Basically your job is to get as much information as possible. So it'd be the difference getting a non-weight bearing view versus a weight bearing view. A non-weight bearing view is essentially unusable to me. It's like, oh, I have a bunion. I need you to stand on it because I need to see the forefoot splay and I need to see how significant that is. Non-weight bearing, it looks like you have a significant cavus, and then how much hypermobility do you have and how much splay do you have? So basically getting as much information as possible is never a bad thing.
Yeah, definitely. I agree. And I also think when you're doing just going back to the OR, understanding how these views function outpatient, extrapolating those angles to running a fluoro machine and understanding what the angles you have to get there are super important too. I mean, where do all hindfoot fusion nails fail? They fail at the calcaneus. So making sure that thing is concentric within the calc, you wouldn't know that if you never took a hindfoot view. How many subtalar fusions have we done and we never take a foot view and realize that distal screw that's angulated obliquely is not even in the talus. It's kind of off to the side laterally. I mean, I've been guilty of that.
Yeah.
Also, not getting an ankle view. We were just talking about that with my fellow the other day, and just making sure that things are situated where they have to be, because you don't want to fuse someone in a position, especially if you're dealing with a potential for collateral ligamentous disruption, whether it's deltoid or lateral collateral. If you don't situate that calcaneus when it's fused, fusing it in situ can cause too much of a valgus moment or too much of a varus moment, and making sure that you're directly in line, taking that appropriate view. So going back to the office, if it's extensive arthritis, I'll usually get a CT scan. I will also, for my flat feet, they're usually going to get an MRI just because I want to see the condition of the soft tissues. I've really started nerding out a lot on spring ligament, looking at both the superficial medial calcaneal navicular contribution as well as the medial oblique calcaneal navicular contribution. So seeing as what can predict whether I'm going to have to do a deltotibial spring imbrication versus a extra anatomic weave of the ultra high molecular weight polyethylene suture tape that runs kind of in a triangle along with the FDL transfer.
Yeah, let's go back to CT real quick. So you're looking at arthritic changes in some sort of a chronic deformity, flat foot, cavus foot, whatever it may be. And then are you using the arthritic changes to determine fusion versus osteotomy? Is that the main distinguishing factor that you're getting information you're getting from the CT scan?
Yeah, I look for the extent of subchondral cyst formation and to see if there's, I wish we had access to weight-bearing CT because I think other functional levels of hypermobility or instability can also guide to which joint levels you're preferentially going to fuse. And I think that's another example where weight-bearing CT can play an active role. Something that oftentimes goes missed if there's a substantial degree of forefoot varus. I think some of those cases, when you're dealing with a really bad stage 3 flat foot, it's hard to tell whether you may need to actually fuse the CC joint to relocate some of that frontal plane deformity. So I'm a big fan of double arthrodesis. I don't do the dipple. I don't do the medial double. I do both 2-incision approach.
Yeah, I think that's reasonable. I've done the medial double, and it's hard. I think maybe I'm just not very good getting to the posterior lateral aspect of the posterior facet of the subtalar joint and the lateral aspect of the talonavicular joint. It's just difficult, like to sacrifice improper joint prep for, a little sinus tarsi or a little small lateral incision. I agree with you. I like to go lateral as well.
Yeah, and I just love that this section is super fun. It's a great teaching moment. You kind of like lift the EDB up right over the perineals. I attended a lab with your mentor, Dr. Burns, and I really like his technique of like really like shucking the hind foot into varus first and just fixing that, and then dialing in the forefoot thereafter.
Yeah.
Yeah, that's always like. And I had the fortune of working with Dr. Lexi Shoup as one of my former fellows, so I got a little Burns in me.
There you go.
Yeah,
that's what we all need.
Felt good. But yeah,
how often are you fusing the CC joint?
I mean, I don't like doing it because it's usually a gap, and I usually have to graft it, especially in these bad abduction deformities.
Yeah.
I really look for, and actually, I try to mobilize it intraoperatively. I try to see if there's a lot of instability there, or if my CC joint's not congruent after the fact. In my Charcos, I've had these really bad forefoot supination deformities, and this can be a topic in and of itself. And by nature of this podcast, I think we'll be going all over the place. But I do believe the future of Charcot recon is lengthening the tibialis anterior tendon as often as we do a TAL. I think that sucker is such a deforming influence in so many different patterns, especially when you deal with this bad forefoot varus. I've had beautiful correction in these forefoot varus deformities where after the fact, it just spun back around because the CC joint wasn't stabilized adequately without prep. We did do a poster, prepping versus non-prepping the CC, but I think if you've got a bad forefoot varus, I think that CC joint has to be prepped.
And you're talking specifically in Charcot?
Yeah, specifically in Charcot, but I think for a traditional sensate individual, I think the double orthodesis does well. What really, I'd be curious what your thoughts are. After attending, I'm not sure if it was last year or the year before, they had that international flat foot panel at ACFAS, and they were discussing with Dr. Hinterman's wife, and she was a big proponent of never fusing the TN. And they were doing a lot of subtalar with NC fusion. And for me, I think the deformity is there. It seems like the most appropriate joint to fuse. I've had less recurrence of flat foot after extra-articular osteotomies, namely if I did an MDCO and like an Evans, where I do the NC fusion in conjunction.
Yeah.
But I can't say that I will abandon a TN fusion for bad end stage AAFD, PTTD, PCFD, whatever you want to call it.
Yeah, that's interesting. I do agree. I'd see a lot of just basically on the lateral weight bearing view, you see that naviculo-cuneiform fault. I always see this it goes like TN and then it goes like NC is right where that little V is, that midfoot fault. And so I agree with you. So then you're wondering, okay, do I need to extend my talonavicular to include the NC? But it's an interesting thought to skip it altogether and go. So CC, wait, what did you say she said?
They just do subtalar and NC.
Subtalar and NC, okay.
And maybe that's another way to check. I've had qualitatively, I can truly say that I've felt greater sagittal plane excursion and hypermobility with a TMT and NC. And I think that at NC, it can happen just as often. So I think that's something to consider. And it may be, again, I do think that the consensus statements and the literature is really shaken out that the plantar flexion of the first ray is a big stability consideration for these flat feet as well.
Yeah, I agree with that. I just did a TMT NC joint fusion this week. I'll be honest, it's not my favorite. I've started using an MIS burr to stick it in there. It makes it a lot easier. I don't have to stick a curette in there. I just stick an MIS burr under fluoro and then microfracture with like a 2.0 drill bit. Seems to be a lot simpler, but there's a bunch of little tiny joints in there and you're trying to get every little nook and cranny. And the TN's no prize either due to the curvature of the TN. I'm not a huge fan of sitting there all day long prepping the TN joint either.
Yeah, and then that dysvascularity. Do you do a dorsomedial approach for your TN or do you do more medial?
I do a little bit more medial.
Yeah, I think it's better for the blood supply.
Yeah.
Yes, but it's harder because then your prep is limited.
Yeah, exactly. And that's what I was saying, trying to get to the lateral aspect with that adjacent incision helping you out there. So what do you think is the hardest part of your job? Is it working with residents? Is it teaching the fellow? Is it the complexity of the cases? Is it Do you ever butt heads with ortho, or is anybody in your system difficult? What's the hardest part about your job?
It's the people at the hospital, which thankfully will never listen to this podcast, are like the administrators, like the ones that have like, like we've got like a badge, and then underneath it's like doctor, and then like it's the people that have like the manager badge.
Yeah.
The manager badge people have all the power, and it is so peculiar. I mean, my friends and family that have listened to me bitch about my job, they're all like, you just deal with so many people. Like I go to the office, I've got like Bob and Sheila, and like that's about it.
Yeah.
Like I just need a Bob and a Sheila, and then I'll be good. But I'm dealing with like OR staff. I could have like a nasty scrub tech one day, and I'm generally like very friendly, and people do like working with me. But when you're there so much, it's like a weird dysfunctional family. So I got the interpersonal stuff in the hospital. It's not bad. It's just again like trying to have a case go, and like the constant metrics that they put, like on time first start, get to the hospital at the right time. Make sure you check everything, and everything is like screw the doctor. It's all like all these other factors that play in. Yeah. I oftentimes equate getting like stuck in the OR and having like a delay, which honestly I think is the most mentally taxing, because you just want to get done and I want to be efficient. I constantly want to do things. But when there's a delay, the analogy I give, it's like going to the restroom, having to do a number 2 and finding out there's no toilet paper after you've already gone. There's like nothing you can do. You are beyond like helpless in there. And that's how it feels, because you can't scrub out and get what you need.
Yeah.
And then like they'll get mad. Like, what are you doing on my table? I'm like, oh my goodness. Please.
Yeah.
It's the things that because of the precision that we're expected to have and the acuity to which we're expected to function at, having a disconnect around us is like the most perplexing. And I think some of that could be different if I was in private practice, could be different if I was at a surgery center that I was part owner in or had shares in, or I don't know how that works. I'm pretending the grass is greener. Like I said, this is my first job. I don't know. But generally speaking, I think working for a big hospital system, there's lots of systemic issues everywhere, and everyone's feeling it. And I don't want to rag on my scrub techs or my circulating nurses or the hospital administrators, because they're up against their own stresses. Yeah. But there's just such a disconnect, and the fact that we work until the job's done, and other people work when the clock's out.
Yeah, I think the higher the number of people there are between you and the top, the more difficult it is, because then you're but you have to deal with the OR manager, and then you have to deal with this person, administrator in the hospital. Then they're answering to this person and it goes like up the chain. And that's more common in hospital-based jobs.
Yeah.
In my job in multi-specialty, we're physician owned. So we have fewer people between me and the top. We have the board of directors, and it's just a more simpler way to do things. Not better or worse, because there's a lot of redeeming factors of working with residents and fellows and working in a large hospital system, and the complexity and the interest of the cases that you're getting is much different than what I'm getting on a daily basis. So there are lots of varieties out there, but yeah, I think the more people there are between you and the top, the more difficult that can be sometimes.
Yeah, it's funny. I mean, the goals aren't really even aligned. Like I'll do these cool big recons, and I'll take like a flat foot and make it low, and I'll take a low foot and make it high. And, I'm like high-fiving, like chest bumping, and like, things look great. OR doesn't know. They're like, what the hell took so long? And why'd the one like last week take all that much less time? I'd like to think that over time, and why it makes it so hard to ever consider leaving is just, the sweat equity put into reputation building, I think, is just huge. And that too is like a constant, I would say, a bit of a stressor in my world, like even for the trainees, like you're only as cool as your last case. If I would have a couple first MTP fusions and just line them up, I'd be like, wow, this is great. You guys can do a lot. No, they're like, where are the frames?
Yeah. Right.
No, but I don't think they're like that, but I do like, you see it on their face when it's like, someone's like, like you realize like their A1C was like 6 and all of a sudden it's like 15. I'm like, sorry, like probably shouldn't do the surgery. Like, oh man.
Yeah.
Like, but I'm off next week. I'm like, I don't care.
No, I really don't care. What are your favorite cases to do? You do a lot of complex things that I'm sure aren't all that fun. What are your favorite cases? You said you like to dive into the spring ligament, and what are your favorite things? You like tendon transfers? What are you digging?
I like the tibialis anterior tendon transfer for these dynamic supination deformities. I do them everywhere from club feet at age 3 to my diabetic and sensei population with wounds and these lateral column wounds, the in-phase transfer is beyond quick. It doesn't require a lot of durability. I mean, I've had them like walk all over it. I know they have.
Yeah.
And I just think it's like the quickest procedure to heal these lateral column pre-ulcerative, ulcerative lesions, and painful supination deformities, even in patients that have a profound degree, what you would attribute to that classic C-shaped foot or that metatarsus adductus.
Mm-hmm.
You don't necessarily correct for that as much, but over time, I do think with the stylus stripping that does settle out. But those two procedures in tandem can work tremendously well as far as relaxing the foot and really promoting that eversion past the metatarsal joint.
So tell people what you're doing. Are you doing a split tibialis anterior or transferring what are you doing?
If they have a pre-existing pes cavus, I'm going to split it because I want to maintain that first ray dorsiflexion. And to be honest, I've had great strength, and I go over the retinaculum just so I can see it, feel it, and perioperatively, even when they come to follow up, I can actually feel and see if it's still intact.
Mm-hmm.
I tenodese it to tertius in addition to routing it through the lateral cuneiform with a biotenodesic screw, and I do a button underneath.
Okay.
That's been just...
So explain that to the younger people. So you're drilling a hole.
Yep.
Are you whip stitching the tendon and then putting you're passing it through the bone. You're using a biotenodesic screw to anchor it into the bone, but you're also putting a suture button on the plantar aspect
yes,
of
sir.
what do you say, the lateral cuneiform or the cuboid?
I do it under the lateral cuneiform, depending on how much eversion I want. So I can circle back the favorite procedure being the tiband transfer, and exactly like you said with the two parts. So you whip stitch it. If it's an infection case, I will not use fiber wire. I will use PDS suture. Not very hard. You just have to practice it ahead of time and just know that you've got two ends that are kind of hanging out. You just have to pinch them and make that your loop as you go. I would say don't use anything below an OPDS for strength, and just be mindful as you do a pull-through technique.
Mm-hmm.
And then I will curettage the back of the tunnel, because normally what you want to do is you want to maintain an oblique excursion of that tendon transfer. Not as much with tibialis anterior. With posterior tibial tendon, I think we run out of a lot of length.
Yeah.
And for that, you need all the tricks in the book.
Yeah.
So I do like to kind of carve out a little oblique wedge as like almost like a slide to let it kind of glide down into the hole. And then you pull through. And then I'll tenodese to the adjacent tendons for either the EDL or the peroneus tertius nearby. And then I will also kind of try to oversew the periosteum over that, but I'll also dunk a biotenodesic screw in, and then I'll do the outside external button over a sponge.
Oh, okay. External. Okay.
Yeah, external button. I don't, that tension slide technique with the bicep button, it's fine when it works.
Yeah.
I don't want to knock industry. I'm sure we all rely on industry. Industry is great. We cannot exist without industry. I love my industry partners, but this particular company that is big into sports has some of the most innovative stuff out there. And it is the most like simple thing until it goes wrong. Mm-hmm. And then you feel like the world's worst surgeon when like there's like a little hiccup with respect to it. It's, I don't know. I mean, that's the kind of thing where with the best laid plans, but I do believe that, I like to put the button on the outside, especially if I've got an interference screw. I think for the post-tip tendon transfer, this tension slide technique is good because you really have to wiggle it down in there, because your own strength to get it in the hole is not going to be sufficient because it usually bunches up at the tip. Mm-hmm. I'll also say that if you are having any issues and you don't feel that give as it goes into your tunnel, I would actually abort, take out the whip stitch, narrow your tendon down, and then re-whip stitch it.
Yeah. Get it into the bone, essentially.
Yep.
So we have a complicated profession. At least we think that it's complicated. Everyone who's the center of their own universe and is certain that all of their issues are the most important issues in the world. So, but we in podiatry know that our profession is complicated. What do you see as the future of our profession for anyone who is younger, interested in going into the field, or where do you think you see the profession moving forward?
Yeah, it's a great question. So I think that we have to determine, based on our path to parity, what that parity is going to resemble mostly. I do think that it has to start with unified reimbursement from insurance companies for the work that we do. And I think that first and foremost is going to really help the profession the most, because at the end of the day, if we can't earn a living, then there's kind of no point in talking about the profession. If the average salary, and I just checked on the East Coast, is a little over like 240. But I just gave a lecture to some pre-health students, and at that time, the ACPM had data. Again, it's antiquated; it was old, but the big pitch was $144,000 a year, and I don't know if that's really for going into all that debt and kind of coming out. Not that it's about the money, because we are all doing it because we generally love medicine. And coming from myself,
and the money, yeah, and the money,
and the fame.
Why do you think I do a podcast?
Exactly. No, I think that, the money's validating because it speaks to our sacrifices of not entering the working world earlier on, like our friends did in business and other aspects. But, I will say the one great thing about any aspect of medicine, and I do think podiatry, is our longevity. And I do think that we have a very sustainable profession. I do think that we are at very low risk of becoming unemployed. I mean, I do think that there will always be a place for a practicing doctor of podiatric medicine for the services that we provide. Mm-hmm. Now, here's where I think our profession may have a little bit of differences. And with that is like, what service should our profession be branded as? And it is a system where our training is now uniform based on the CPME, Council on Podiatric Medical Education. Mm-hmm. And they do an excellent job of creating minimal standards so that all programs of residency training are equivalent. But the fact is, and you alluded to this earlier in this podcast, is that not everybody wants to do the same thing when they get out. Mm-hmm. And this was brought up actually at one of the ACFAS roundtables when we had a consortium of both allopathic and podiatry folks up there. And, the biggest thing was, we can't expect folks right out of undergrad to commit to wanting to become surgeons. But I do think they have to learn about the surgery, because it's going to be there. And I do think that you're providing your patient somewhat of a disservice if you don't exactly know what that surgical procedure could look like, mm-hmm. or the type of problem the patient has. And going back to what I said earlier, there's certain conditions that I think if it's a non-braceable extremity, or if it's a tendon that is torn and retracted, there's very little conservative measures, I think, that can be used to help that. You can support it, and you can not put a Band-Aid on it per se, but it's going to be hard to get people to complete functional status without a surgery in some instances. Now, there are plenty of problems, and I would say more than 50% of foot and ankle pathology can be treated conservatively if it's done appropriately through therapy, through multimodal treatments, we don't want to go the medicinal route, but we do have our pain management colleagues that work with multimodal therapies, help these patients along too. And the purpose of me going on this kind of soapbox is not to alienate our non-operative providers. I do think I too like to non-op my patients as much as possible going through the process. But I think the future is going to be folks that are going to embrace it, and ones that are going to sort of say, well, this really is not going to be for me. And I want to find an avenue that's going to be good for my lifestyle, good for my family, and good for my own personal growth as a human and what I want out of my life. And I think that's going to be a tough thing to sort out as we move forward, because I think that I'm seeing, at least from the resident perspective, just because you go to a residency and I'm sure even in your residency program, you may have had people that have gone on to pursue non-operative podiatry, even though they went to an elite podiatric medical education environment. So I just don't know how to reconcile or how to predict how many surgical providers, hybrid providers, or completely non-op providers we're going to have in the future. But I would like to see in the future more individuals embracing innovation and education, and understanding that they still have to continue to grow and evolve. But I also don't know how much complacency exists in allopathic and osteopathic medicine, PT, chiropractic, or whatever have you. Mm-hmm. So I don't know where the future is going to be.
I don't think any of us do. I think that's reasonable. And a couple of guests have brought up very similar thoughts as you in the past. Is, not everyone is meant to be a surgeon, and not everyone is capable, even though if they intend to be a surgeon, not everyone is capable to be a surgeon. So figuring that out sooner rather than later, because the non-operative component of the profession, any profession, is is the majority of what I do. You're probably different in a tertiary referral system. I spend far more time of my day non-operatively helping people than I do operatively. That's just the nature of my practice. Someone falls and breaks something, okay, I'll fix it. But I have 40, 45 patients, that's 40, 45 patients to one fracture, and then it evens out. Maybe I'll get a couple fractures or something. But the majority of my time, even as a surgeon, is spent doing non-operative things. So I think we have to be a little bit careful diving too far down the realm of surgery, and especially residencies that are so hyper-focused on surgery, and neglecting the non-operative aspects of the profession is a little bit dangerous to me.
Yeah, I think so. And it amazes me too. And it's hard because residents view the quality of their program as to how much ratio they have of OR to clinic, and they hate clinic, and we all hate clinic. Okay. I don't hate clinic. I hate the charting after the clinic because I got to relive the pain.
Yeah.
Like after the fact, it's like almost like, have you ever noticed that when you document on a patient, it takes you longer to document on them than it took you to like work them up?
Yeah.
And we're talking like procedures, injections, whatever have you too. So,
yeah.
But yeah, I do think that understanding what the conservative modalities are, and that's why I think there has to be a place in our educational system, whether it be through APMA or ACFAS or other conference tracks that do focus, a little bit of both, and not just like, how many times have we gone and we listened to a surgery talk and it's like, like non-operative treatments, PT, bracing, like what does that mean? Like what kind of bracing? Like what are you offering them? Like what kind of boot?
Yeah.
And
what kind of PT, what kind of exercises, let's take a deep dive into that. Let's spend a little bit more time with that. I completely agree with you.
Yeah. So it's not, I think it's undersold. And I do think that there's an art to it as well. And what I don't want to happen is people take away my discussion of some people needing surgery as like, it is the panacea, but I definitely think that non-op is great and it's important, but it's got to be done well too. Just ordering bilateral foot ankle MRIs and putting a patient in a cam walker boot and an Una boot together, I don't think it's great non-operative management.
Unless you're working with a orthopedic surgeon who wants to get some wrist fractures out of the deal.
Yeah, exactly.
Drum up some business for them.
Even the rolling knee scooters aren't benign. People are having like DVTs from them.
Yeah. I've had people fall off and do some damage. So, all right, I think we'll leave it off there. I think we're going to have to turn this into a part 1 and part 2 because we're just getting started with Jake Wynes here. We are just dusting off the surface of this magic genie lamp of all the information that's inside. So let's leave it off there for part 1. Thanks for joining me on the season premiere, season 2, season premiere. Jake Wynes, thanks for joining me today. Let's hit it back with part 2 coming up next week. But for now, we'll leave it off. Thanks, Jake.
Thank you.
Thanks for joining us on this episode of Paw Patrol. We'll catch you next time for part 2 with Jake Wynes. Till next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.